Rehab is actually very timely and relevant, especially these days, wherein COVID-19 continues to limit the access to face-to-face rehabilitation services. Just to put it into context, let's imagine a stroke patient who is in need of rehabilitation services but is unable to access them because of several factors, such as topography, especially when the patient is in an area that is geographically isolated and disadvantaged, wherein usually there is no rehabilitation professional in the area, or more so any rehabilitation facility. Another challenge is the costs. When we talk about costs, we remember the direct and the indirect costs of care. The direct costs include the actual consultation and the therapy fees that the patient has to pay for regular therapy sessions, while the indirect costs of care include the travel expenses to and from the rehabilitation center, the meal expenses of the patient and the family member who accompanies the patient, and even the loss of day's productivity. Another challenge is the sustainability of some community-delivered rehabilitation programs. And of course, we have the rehabilitation workforce shortage, among other challenges as well, although not listed here. But I'm sure you can name other challenges. Well, just to give you some data, we really have a limited number of rehabilitation professionals throughout the country, majority of whom are actually based in urban areas. So you can just imagine the increasing gap between the supply and demand for rehabilitation services. That's why we can actually leverage telehealth solutions in order to bridge the gap between the supply and demand. Telehealth, as we know, refers to the use of electronic means for information and telecommunications technologies to provide clinical health care, health-related education, public health, and health administration over a distance. And under telehealth or telemedicine, we have telerehabilitation, just like other forms of tele, like telemedicine, teleneuro, telecardiology, telederma, and the rest. Now, telerehabilitation refers specifically to the provision of rehab services to patients over a distance. We can do this by demonstrating certain exercises through video call, and in other advanced healthcare settings, they even have developed technologies such as virtual reality and motion sensors that can facilitate remote conduct of teletherapy. In telerehab, let us remember that we provide the usual services as we do in face-to-face consult, but this time in an innovative or in a new way in order to adapt to the changing needs and times. But nevertheless, in tele, we can do the usual history taking. We can be also creative in the physical examination by, of course, performing functional assessment remotely, and even doing certain maneuvers or special tests through tele. And we can even measure range of motion through certain applications that can provide objective measure of range of motion. And through tele, we can actually provide treatment recommendations, monitoring, supervision, patient education, consultation, and counseling. Let us remember that telerehab is not really a new service, but rather a new way of delivering the usual services. And there are a lot of benefits we can gain from providing telerehab for our patients. One is less need for travel. We minimize the direct and indirect costs of rehab care. We overcome disability-related limitations, such as the difficulty in transferring a patient from one place to another because of inability to ambulate. Time flexibility is another benefit. Improved access to specialized rehab care or services. We also can provide educational benefits and empowerment for patients and their caregivers or family. And through Tele, we can actually provide enjoyable, varied, and interactive multimedia communication while exercising. Now, there are various forms of telemedicine, such as synchronous or the live format, like a video call. Another is story forward or synchronous technique, which has the time element of delay. An example which is e-names. Third is remote patient monitoring, wherein we use certain technologies in order to track patients' health-related information. And this information is transmitted to a clinician over a distance. If you're familiar with the RX box, of course, that can actually transmit, for example, blood pressure, and even ECG monitoring or traces to a remote clinician. And another common example of telemedicine, which we can use for telerehab, is mobile health or mHealth, which is the use of cell phones or tablets to send messages to patients to exercise, to promote healthy behavior, remind them of certain medications or instructions, and basically to provide health-related information to patients using mobile devices. And through telerehabilitation, we can actually engage with partners or other stakeholders, such as the municipal health officer of the rural health unit, who will be included in this focus group discussion. We conducted an FGD before we actually tried to pilot for telerehabilitation in Philippine General Hospital. We also engaged with the National Telehealth Center to guide us in the proper conduct of telemedicine. We also partnered with the Community Health and Development Program of the University of the Philippines, Manila. And together with us are the different members of the rehabilitation team, the physical therapists, occupational therapists, speech pathologists, even psychologists, and rehabilitation nurses. And this rehab team is led by the rehabilitation medicine physicians. And before we conducted the actual telerehabilitation, we, of course, did a test run or a dry run of the technology setup. So with telerehab, from the community, they were able to tele-refer their patient to us. And on the other side, the rehabilitation team is ready to accept the referral. So it's like a multidisciplinary team conference, wherein we have the doctor together with the So as mentioned, we have the telerehab team. And let's remember that the patient should still be at the center, as always, like in face-to-face rehab. And around him or her, we have the different members of the rehab team. Convening in order to help a practicing physician, whether the municipal health officer there, or a resident physician living in the community, or a barangay health worker. And now, for the actual telerehabilitation session, so we received the tele-referral, and we even can verify certain physical examination findings through tele. And towards the management part, we can provide demonstrations of exercises to the patient, and afterwards the patient can return the demonstration to ensure accuracy and safety of the exercises before sending the patient home. So this is how a telehealth encounter works. A rural patient has a health issue, for example, stroke, and then the local physician co-located with the patient reviews the issue and performs the routine history and physical examination of the patient, and if needed, refers the patient to a remote specialist. And now, for example, in our case, the Telerehab team is willing to accept the tele-referral and provide appropriate rehabilitation recommendations. So here, it is important to always orient both the sites, the spoke and the hub. Okay? So the tele-community team and the Telerehab team. And then we identify the patient. It is important to engage the family in order to encourage active participation in the recovery or the rehabilitation process of the patient. And then we arrive at assessment and goal setting for the rehab. Then we provide appropriate rehabilitation interventions and recommendations. We monitor or follow up, and we eventually discharge the patient from rehab if the patient's goals have been achieved. However, of course, it is easier said than done. There have been many challenges to the emergence of telerehab according to our study. We did a systematic review and found several factors that may challenge the practice of telerehabilitation in our country. And the most common of which is related to organizational factors. But in terms of specific challenges, slow internet or fluctuating internet connection accounts for the highest number of citations or challenges. And in terms of human factors, it is the skepticism or the lack of acceptance to this rehabilitation technology. But I think awareness campaigns such as this one can improve the acceptance to this emerging rehabilitation technology. And having national e-health policies or regulations in place can mitigate the risks related to telehealth efforts. Nevertheless, in the PARM, or the Philippine Academy of Rehab Medicine, CPG, it is recommended to have telerehabilitation, especially for the upper extremity in underserved populations. Well, this is according to evidence. And the Stroke Society of the Philippines Stroke Rehabilitation Guidelines states that the use of telerehab has only recently emerged and is likely to become increasingly viable as ICT become more sophisticated and user-friendly. It is important that the rehab professionals, whether doctors or therapists, consider how their practice may be adapted so that services can be delivered remotely. Now, let us talk about the process of conducting telerehab. We can divide the steps in before telerehab, during telerehab, and after telerehab. Before telerehab, there are several steps. We have to always secure informed consent first, then choose a telehealth platform that is agreeable to both sides, depending on the patient's needs, and of course the available technical resources in both sides, plus the digital know-how. Then we set up the virtual rehabilitation clinic. In the virtual rehabilitation clinic, we try to mimic how the actual face-to-face rehabilitation clinic looks like. Of course, the rehabilitation area should have an adequate space in performing the exercise. There should be a safe space for the patient to perform certain movements. And if needed, there are vital sign monitoring devices in order to gauge the patient's response or tolerance to exercise. And of course, we can also advise our patients to have certain household items as surrogate or substitute for exercise equipment ready for the actual telerehab sessions. So if there's no dumbbell at home, then the patient can use a bottle of water, for example. Then we arrange the schedule of rehabilitation sessions. Usually, we do telerehab regularly, for example, 3 times a week, so just like face-to-face rehabilitation. So we schedule the telerehab sessions. And if possible, we instruct the patient or a reliable caregiver on the proper monitoring of vital signs or self-monitoring guidelines, such as the ones in the table. We advise the patient to wear proper clothing for exercise and follow pacing or exercise guidelines. And we educate the patient on proper precautions and symptoms that will alert the patient to stop exercising for cardiac or general symptoms. We also do not advocate to exercise when febrile or in environmental extremes or after eating. Alright, so during telerehab, before proceeding with the actual demonstration of exercises, we have to check first for new or emergency symptoms. And if warranted, we advise the patient to proceed to the nearest healthcare facility face-to-face. Then we identify a reliable caregiver if the patient is already stable. We proceed to the pre-exercise monitoring of vital signs. We evaluate the patient. Then we institute the demonstration of exercises. We ask for return demonstration. Then, after the rehabilitation program has been executed as prescribed by the rehabilitation doctor, then the therapist monitors the post-exercise vital signs. Then we educate the patient and ensure understanding before ending each telerehabilitation video call. These examples, such as the board or modified board scale, can be used to monitor response or tolerance to exercise. Or the modified board business scale can also be used. And as mentioned, we can use common household items either to measure or gauge the strength of the patient or as an exercise equipment during the actual teletherapy session. And for stroke, we can actually engage the patient to perform self-assisted exercises by using the strength of the strong limb. So we demonstrate exercises to the patient remotely, or we can show pictures or share our screen to our chosen video conferencing platform, or sometimes we even show some videos available online. Or if you want, you can create your own video exercises to show to our patients. And we can also engage them in active assistive exercises with the use of household items like an umbrella, or a wand, or a cane. A towel, for example, can also be used. And towards the latter part of the exercise, we ensure proper understanding, and sometimes we even give them home exercises by showing certain videos or demonstrations. And let us not forget to properly document our teleconsult or teletherapy session. We accomplish our charting and send home instructions if needed to the patient. And we might want to ask for feedback every after sessions, so we can always improve the quality of care. Alright, so as takeaway message, telerehab is actually an alternative, innovative way of delivering rehab services to underserved stroke patients and their families. Let's leverage information and communications technologies to facilitate health-related communication between the rehabilitation specialist and patient in a remote location. Based on growing evidence of effectiveness abroad, efforts must be made to study its applicability in our setting in order to provide more evidence locally and hopefully achieve a greater adoption of telerehabilitation in the Philippines, especially if we wish to achieve universal health care. So with that, thank you very much for your time.